Thank you all for joining us today for the Susan G. Komen's Educate and Empower Launch and Learn event. It is October, which means it is National Breast Cancer Awareness Month. We hope the speaker we have for you today will not only raise your awareness of the choices you have in your breast cancer care, but will also empower you with the information you need to take action and prioritize your health and your quality of life. My name is Lorena Placencia, and I am happy to serve as your MC today for Komen's Educate and Empower program. In my role as a news anchor for Telemundo Austin, I am always grateful to be part and show support to organizations like Komen and Texas Oncology, who are bringing the community resources and education that help them improve their quality of life, especially as it involves a breast cancer diagnosis and treatment. So did you know it is Hispanic Heritage Month? Komen is hard at work to reduce disparities for all communities. And for Hispanic and Latina women like myself, we appreciate the bilingual support Komen provides through their breast cancer helpline and education materials. Today's program and those coming this month will serve to empower all of us. Komen, in partnership with Texas Oncology, is offering another Launch and Learn event in this series. Please be sure to register and consider the Advocacy Metastatic Breast Cancer Series and Breast Health Forum, also happening during Breast Cancer Awareness Month. As you look over this information, we have a few housekeeping items. We welcome you from wherever you are and encourage you to put your questions in the Q&A section throughout the presentation, so don't be shy. We will present your questions after the presentation. So let's get started. Our topic today is reducing toxicity during treatment. The side effects of cancer treatment can impact physical and emotional health. We'll learn from Dr. Mika Cline the methods and choices available to reduce the toxicity from both short and long-term quality of life, including reducing hair loss using cold caps, reducing toxicity using diet, and a brief overview of fertility preservation during treatment. Dr. Mika Cline is a board-certified medical oncologist at Texas Oncology, Austin Midtown, and Marble Falls. She has a special interest in cancers of the gastrointestinal tract, as well as clinical research within oncology. She practices in and advocates for clinical cancer research within community oncology practices. Prior to joining Texas Oncology, Dr. Cline worked at the Cleveland Clinic in gastrointestinal cancers, in addition to having worked with the U.S. Oncology Network in Nevada. So welcome, Dr. Cline, and thank you so much for being here with us today.
Thank you so much. I'm so pleased to be here, and thank you to the Susan Komen Foundation for having me. And so I'm going to talk a little bit today about strategies to reduce toxicity from chemotherapy. You know, a necessary evil at times. I'm going to focus more on things like hair loss, and actually I'm talking more about prevention of neuropathy, which is such a common complaint for my patients, and also dietary modification to try to ameliorate toxicity, just because it's a fascinating topic, an area that's being studied. So I'm ready to get started. If the person wants to go to the first slide. First, we'll talk about hair loss. So chemotherapy is cytotoxic. What that means is it directly kills cells. So, just as an aside a little bit, there's been a real, it's getting there in breast cancer, but a real revolution in cancer medicine. It used to be that the arrows in our quiver were mostly chemotherapy, but that's pretty harsh medicine. In the last 5 years, there's been a real revolution in that we're starting to incorporate immunotherapies in areas of cancer treatment, and that's starting to come into breast cancer treatment as well. But for the sake of this talk, we're talking about how to ameliorate toxicity from chemotherapy, because in breast cancer, unfortunately, a significant number of women are going to be exposed to chemotherapy, even in early stage cancer, especially if you have high risk disease. And so hair loss is a real concern. I have women that say to me that they struggle a lot with the hair loss because it's a visible reminder of what they're going through. And it also is a visible reminder to their friends and family. And they don't like that, and I don't blame them. And it's the nature of the beast of chemotherapy. So it's directly cell killing. Chemotherapy works best on rapidly growing and dividing cells, which basically characterizes tumor. And so its efficacy, unfortunately, is tied to its toxicity. So what makes it helpful in controlling cancer also makes it toxic. So we expect it to impact areas of the body where the cells are undergoing more cell turnover: your skin, hair, your gut, and blood cells. Next slide, please. So I just put up a picture of a hair follicle and the hair coming out of it. And if you get down to the middle words on the right, you can see the matrix. That's kind of where the action is. This is where they're dividing cells. That is what is driving your hair growth. Hair grows, maybe up to a ½ inch a month or 0.3 millimeters a day. And you've probably heard that your hair can be in an active growth stage, a regression stage, a resting stage, and finally a shedding stage where your hair comes out. At any one time, greater than 80% of the hair follicles are in the growth phase, and so those cells are active, and thus why they may be vulnerable to the toxic effects of chemotherapy. So once that chemotherapy is, put in the vein and it goes into the bloodstream and goes all over to fight your cancer cells, unfortunately, it also goes all over and can cause toxicity. Next slide, please. Okay, so your chemotherapy, you get your chemotherapy, it circulates in the blood, it circulates to the matrix of the hair follicle, and that, of course, affects those dividing cells. The production of hair is then severely inhibited at the matrix, and the hair then is shed at the bulb. With some chemotherapies, it can also break off at the orifice where the follicle is coming out to the skin, and loss of hair can be complete or incomplete. I have a lot of people say to me when this process happens, most of the time about 2 to 3 weeks after you take heavy duty chemotherapy. So you may take, if the doctor or the nurse hasn't explained this to you, you may take chemotherapy and, the first week you think, oh, well, I'm not losing any hair. Well, 2 to 3 weeks is really what it takes for it to really shed. And when it does, it'll come out in clumps. I tell my patients all the time, you may want to shave your head because you're going to wake up and there's going to be hair all over your pillow and down your back. And it just gets so annoying that most people do take that step. And a lot of women tell me that, not only am I losing hair, but the follicles feel, my scalp is tender. And that's because it's affecting those hair follicles. Next slide, please. I'm sorry. For some reason, my dictation system came on and it started to dictate as I'm talking. Okay, so with hair loss again, there is an area of the follicle called the bulge that's kind of in the middle in purple. And that contains the quiescent stem cells. And so because those stem cells are quiescent, they're not actively dividing most of the time, they can be spared the harsher effects of chemotherapy. And that is why loss of hair induced by chemotherapy is usually reversible, almost always reversible. You have to, of course, get out from chemotherapy. In about 6 weeks, you might start noticing some emergence of hair. And I think because we haven't been bald since we were babies, that's also another unpleasant surprise is how long it takes for the hair to come and cover your scalp. It does take quite a while. Next slide, please. So, can we do anything? Can we prevent hair loss? You know, I think we've gotten a lot more sensitive about this as women have come to us and said, hey, you know, it'd be really great if I could not lose, if there were a way I could not lose my hair. Unfortunately, the only thing that has been shown to work was scalp cooling, which, yay, I'm glad that it works. I wish there were more options because it can be a bit cumbersome, but at least we do have something. So I listed in 2015, there was a meta-analysis study. And what a meta-analysis is, for those of you who aren't familiar with that, it's a grouping of studies. So there may be, you know, 4, 5, 6 studies, and you want to look at all of the results and you want to summarize the overall gist of the studies. That's a meta-analysis. And the meta-analysis that looked at prevention, studies that looked at hair loss concluded scalp cooling was really the only intervention that meaningfully prevented chemotherapy-induced hair loss. It's not perfect by any stretch of the imagination, but it does definitely impact that. It's been used in dozens of countries. The efficacy is variable. It depends on a lot of factors. Number one, it depends on the type of chemotherapy. A lot of women with breast cancer, they're exposed to an anthracycline-based chemotherapy or doxorubicin, also known amongst you ladies as the red devil. That one is more challenging. That drug has proven to be more resistant to us trying to prevent hair loss. It can still work. I've seen it happen. Other reasons that efficacy might be different is that adherence to protocol, you have to adhere to the protocol pretty strictly or it's not going to work. And that can be difficult. It requires a significant investment of time, and it can be prohibitively expensive as well. And so those are all challenges that we face in, you know, trying to give women this option. Next slide, please. Okay, so how does this work? This works by placing a cap on the head that is either that's going to have something in it to lower the temperature of the scalp. What does that do? It's actually pretty simple, really. It's, you know, when you get cold, your fingers might turn blue, and that's because there's vasoconstriction going on. There's constriction of the blood vessels. So same concept. You put the cap on, it's either going to have a cooling fluid circulating through it, or maybe you've rented a cap from another business or the internet, and you have to pack it with dry ice. What that's going to do, it's going to cool your scalp, and it's going to constrict blood vessels that are supplying those hair follicles. When that happens, as you would think, you get less chemotherapy delivery to the hair follicle, so you get less toxic exposure. And that picture is of a system we have in our office, the Paxman cold cap system, which it can be costly, but is pretty convenient in that you don't have to pack it yourself with dry ice. You put it on, it circulates, and then you take it off when you're done. Next slide, please. So as I said before, some systems are hooked up to a machine to provide cooling. Others you rent, and you have to pack them with dry ice. That's pretty cumbersome. I've seen some women that are pretty dedicated, and they do it. And there's the side effects. So as you can imagine, when you put something that's freezing cold on your scalp, even though you've got your hair, you can get a headache. You can feel cold. That can lead to discontinuation. So success varies. Next slide, please. So in one multi-center study, and these were women who received chemotherapy for breast cancer, but of note, they did not receive the red devil. And they used a specific type of cold cap. It was about 100 women. And 2/3 of those women who used the cold cap experienced 50% or less hair loss. That is considered success. I mean, you might think 50%, yeah, that sounds like it's a lot. Out of the 16 women that served as controls in the study, they all lost most all or all of their hair. Now, also, they looked at quality of life in this study. And I will say, compared to the control group, there were 3 quality of life indicators that were improved in the women that did use the cold cap: their perception of hair loss, their feelings about being upset over their hair loss, and the feeling of feeling less physically attractive as a result of their cancer treatment. Next slide, please. And there was another study using the Paxman cold cap, which is the one I showed you a couple slides for. This enrolled multiple women, and these women had different types of chemotherapy, including anthracycline chemotherapy, or the red devil. Again, in the study, success meant 50% or less hair loss. And that occurred, so success occurred in about 50% of the patients using the Paxman cold cap. The control group, which did not use the cold cap and got chemotherapy, had 0% hair retention. However, it's noted that when they apportioned out the patients who received the anthracycline chemotherapy, only 16% of patients in the treatment group who received that had success as defined by the authors, which is 50% or less hair loss. So that tells you that that continues to be a great challenge. Okay, so conclusions for hair loss prevention. Success varies. Again, it depends on the chemotherapy regimen and adherence. For patients, you should know it can be done, but it can be quite a task, an investment of significant time and money. And you know, when you're tired from chemotherapy, the thought of having to do one more thing and to be pretty regimented about it can be difficult. And in addition, side effects, feeling cold, getting headaches, very unpleasant, and that can also lead to discontinuation of the device. But there is something out there. Next slide, please. Okay, on the same level, we're talking a lot about cold today. So I was interested in looking at neuropathy. I'm actually talking about that in lieu of fertility preservation, although we can touch upon that in the questions, just because it impacts so many of my patients. Oftentimes, patients who have earlier stage breast cancer who get chemotherapy, they're going to be exposed to anthracycline chemotherapy and taxanes. Whereas women with stage 4 breast cancer, they won't necessarily receive anthracycline chemotherapy. Most everybody who receives chemotherapy for breast cancer, whether early stage, late stage, they get taxane chemotherapy. And depending on the taxane, you can get a lot of neuropathy, peripheral neuropathy. It's a very common side effect of multiple chemotherapies, including taxane chemotherapy, specifically paclitaxel, very commonly used to treat breast cancer. And when I say peripheral neuropathy, what I mean is damage to the small nerve endings in your extremities, especially the fingers, hands, and the feet, toes. Your symptoms will include numbness and tingling. Sometimes it can include a burning sensation. The area feels like it's asleep, and the causes damage to small peripheral nerves. Some patients are going to be at higher risk for that, especially patients who have diabetes, especially if it's long-standing, because diabetes itself is a risk factor for peripheral neuropathy. And so it's not uncommon. Patients come in and they have diabetes, and I ask them about peripheral neuropathy. They don't have too much, and then the chemotherapy then unmasks it because they already were driving towards that or had a tendency towards that. With paclitaxel, the neuropathy, it usually fades over time, but I have plenty of women in my clinic who can have permanent residual symptoms. I mean, these are women who said, yeah, it got better. It certainly got better 6 months, a year later, but you know, 5 years out, I still have a little bit of numbness and tingling at certain times. And we typically manage the symptoms with medication, but that doesn't prevent or fix the problem. Okay, so can we prevent it? Yes, maybe. And so I've been learning about this more recently and have been starting to tell my patients about this. Okay, so there was a retrospective study of Danish patients who were on docetaxel, which is similar to paclitaxel, although docetaxel really has less neuropathy than paclitaxel, but there is some. 40% of the patients in this that they looked at used frozen gloves and socks during their chemotherapy. Now, for these patients, they were probably trying to prevent nail toxicity. Docetaxel is well known to cause avulsion of the nail, and which I would be interested in preventing too, because that can really be bothersome. It can get secondarily infected. But what they noticed is that 44% of the patients using the frozen gloves and socks had a reduction in neuropathy symptoms. Next slide, please. And there was a 2016 abstract report at ASCO. ASCO is our big clinical cancer research organization, the American Society of Clinical Oncology. This is an interesting study, and I'm smiling because I was surprised that they were able to get patients to do it. It was done in Japan, which may explain it. They took 44 patients who were on chemotherapy that was known to cause neuropathy, and they were instructed to take one glove and one frozen sock and put it on one side only and leave the other side free. I mean, it's a good study because, boy, you would really get a good idea if this would work. Patients were given a monofilament test. This is often used in diabetics to test the beginnings of neuropathy. And what they looked at was, hey, did the monofilament test that we gave to people serially, did they get worse? And what they found was that in the hand that consistently got cryotherapy or an ice pack or the frozen glove, they had perhaps a 28% report of worsening. The control hand, it was a worsening 80% of the time. Same thing with the foot, about 25% of the time it was worse. And then the foot that was never iced, 64% of the time was worse. And they also did a symptom questionnaire about patients' perceptions because the monofilament test is quite sensitive and it may get worse before you overtly are aware that you're having the symptoms. And on the questionnaire, patients reported that about 20% of the time that they felt they were worse as far as neuropathy symptoms. But in the control hand and foot, it was nearly 70% of the time. So big difference there. And this was using paclitaxel. And these were patients with breast cancer. I'm still amazed they were able to do that study. But anyway, next slide. Okay, so just to wrap up about neuropathy, this is something that I'm really excited about, and I am telling patients to consider. You can buy the gloves and socks that you put in your freezer, I think through Amazon or online. But if we don't have that, if I have a patient I've just told them they're starting chemotherapy that day, we'll even give them ice packs and just say, just keep them on your hands and feet. Now, there are limitations to that. Again, just like with the scalp cooling, that can be unpleasant. If a patient has Raynaud's syndrome, that's a condition where cold causes vasoconstriction of their fingertips and they turn blue. Well, then you're probably not going to be able to do that. And there are a few other medical conditions where you might not be able to do that or tolerate it. But I think it's great, especially for patients who already have an underlying predisposition to neuropathy, such as diabetics. Now I'm going to shift gears a little bit and talk about some toxicity prevention in general. Chemotherapy, you know, it's poison. It's not sugar water, and it's not a walk in the park to take. And even though with breast cancer, a lot of the patients are younger that are going through it and they tolerate it a lot better, it's still difficult. Oftentimes, the women may have children they have to, and a family they have to take care of, or they're also trying to work a job. And so they're especially interested in toxicity prevention. You know, in the past and the present, we use medications, and we still do, and that's still very important. I would say there's been a real revolution in nausea prevention. We've gotten much better at that. 10 years ago, nausea was a paramount concern to patients, probably because we all remember seeing chemotherapy patients years ago, you know, who were basically living in the bathroom because they were so nauseated, and that is just a miserable feeling. Well, we've gotten so much better at preventing and treating nausea that it is not uncommon for me to hear from patients who are coming in for the next round of chemotherapy saying, you know, I really had minimal nausea, and I'm always so gratified that we're able to find something that works for that particular patient. But can we do anything more holistically? And the answer is possibly. And so I'm going to talk a little bit about fasting during chemotherapy, or following a diet that introduces a fasting type state or a fasting mimicking state. We do that by modifying the diet around the time of chemotherapy. That has been studied, and it is being studied. It's continuing to be studied. It is challenging to study that just because there are so many other factors induced by the chemotherapy that make it difficult. It's also been difficult to study because of the doctors. There's been this prevailing view that because chemotherapy causes nausea and loss of appetite, we seem to be always worried that, oh, my patient's going to lose weight. We should not encourage fasting during cancer treatment. Well, as anyone who treats a lot of cancer patients knows, patients don't always lose weight. Sometimes they gain weight and they're not real happy about it. And I can't blame them. And that's from a combination of factors. You know, the metabolism slows down during chemotherapy. Patients are, of course, feel sluggish and yucky and they're moving around less. They might be really tired. And so for some patients, when you're tired, you reach for carbohydrates. That can actually result in weight gain. I have had patients get upset with me and say, look, I expected to lose weight and I'm gaining weight. This should not be. So maybe we should not avoid dietary modification during treatment is my point. Next slide, please. Okay, so everybody knows about fasting. It's traditionally been part of religious practice during Ramadan, and also, you know, it used to be that you fast during certain holidays. And interestingly, if you read the literature, it has been used to help ameliorate symptoms from other diseases. For instance, you can go in the literature and find reports from patients with autoimmune disease, such as multiple sclerosis, and they will claim that, hey, when I fast, my multiple sclerosis gets better. And so it has interesting effects on the immune system. Now, people mean different things by fasting or fasting diet or a ketogenic diet, which I'll touch on, I'll talk about. So what are the effects of fasting? Well, it depends on the length of the fast. So fasting, some people say, well, I fast every day. And what they really mean is that they're participating in time-restricted eating. So they may not eat from 8 o'clock in the evening to noon the next day. That's known as time-restricted eating, which also may have health benefits. That's another subject, but a long overnight fasting period may be helpful for disease prevention, including breast cancer prevention. Again, that's a subject for another day. But the effects of fasting depend on the length of the fast. The effects are different if you're doing time-restricted eating versus a 24-hour fast versus a 48-hour or longer fast. When we're talking about fasting or following or inducing a fasting mimicking state, even if you're eating, to get the greatest effects, or if you're looking to impact certain diseases like autoimmune disease, or you're pre-diabetic and you're trying to prevent diabetes, to get the greatest effects, some researchers suggest that you need to induce this state for greater than 48 hours. However, I've had patients come in to see me, and one of them nearly gave me a heart attack because we were talking about she had wanted to control her weight and she wanted to do something for her health. And she came in and she said, I did a water-only fast for 5 days and I felt great and I about choked, because that can be dangerous. When you are only drinking water without any solutes, you can derange your electrolytes, and that can have big problems. So I don't recommend a water-only fast for days and days and days. Depending on the length of the fast, patients can experience, and this is for general health, patients can experience a reduction in their weight, their blood glucose, their triglycerides, abdominal fat, and insulin and insulin-like growth factor, which may have repercussions down the line for chronic health issues like diabetes, development of cancer, etc. Next slide, please. Okay, so I touched on, is there a way to get the benefits of fasting but not actually fasting? Yes, and I prefer it because I certainly don't want someone to drop their sodium level, you know, to 116. I mean, I don't think they would go that far, but to drop their sodium level low, it would be very unpleasant and could even be dangerous. And at least if you are eating something, you're probably salting your food, you're probably fine. So whether you fast or you induce a fasting state, the goal is to get to a ketogenic state. And so that has been all the rage as far as diets, ketogenic diet. And so what is that? So ketogenesis is the generation of ketone bodies for fuel. So some of you ladies may have had a PET scan. And when I explain, hey, you're going to have a PET scan, how does that differ from a CAT scan? A PET scan is a metabolic scan, and it's where labeled glucose or sugar is injected into your bloodstream, and it goes all over because all of your tissues run on glucose, right? Especially your brain, which will suck it all up and light up like a fireball. So your tissues run on glucose. Tumors run on glucose. Areas of higher metabolism like tumors run on glucose. But your body can also run on ketones. Ketone bodies are generated through the breakdown of fat and fatty acids. And in times of starvation, if you don't have any food, the body starts breaking down your own muscle and your own fat. Ketone bodies are generated. Normal tissue can use that for fuel. Even your brain can use it for fuel, although it's not the preferred fuel. Do tumors use ketones? Maybe not so much. The studies on that are mixed. There are mouse studies showing that fasting or a ketogenic diet, which decreases glucose availability, might even slow tumor growth. There are at least a couple of in vitro studies, I want to stress in vitro, that suggest that certain ketones might drive, sorry, I just had something pop up on my screen, cancer growth. So I don't think we're all the way there yet, but for the most part, the studies I've seen in the lab suggest that tumors really prefer to run on glucose, and it's difficult for them to utilize ketone. Okay, next slide, please. Okay, so this concept of toxicity prevention, it's similar to the cold cap, and basically it's to induce a kind of dormant or resting state. You influence by fasting or fasting mimicking and going into ketogenesis, where there's just not a lot of glucose being generated. You influence your normal tissue to be less active, and you potentially decrease exposure to chemotherapy. And here's the thing. Tumors in general cannot be less active. They're always turned on. And so theoretically, they should get the full exposure of the chemotherapy. So by doing the ketogenic diet and denying glucose, you should not adversely affect the treatment goals of the chemotherapy towards the tumor. Next slide, please. Okay, so there was one of the researchers who's looked at this the most, who I've read and listened to, is an Italian researcher, PhD, named Dr. Walter Longo. And he is head of the Longevity Institute at USC, and he's been studying this a long time. And he got interested in this because one of his mentors was Dr. Roy Wolford. And that name may not mean anything to you, but if you've been around long enough, Roy Wolford was one of these pioneers back 20, 30 years ago, who really brought on the concept of calorie restriction to lengthen life. And he would talk about chronically eating a diet that was 30% fewer calories to lengthen life. And it could work. These patients, though, they looked like they could belong in a famine story. I mean, it looked bad. And he recollects that may, or not Dr. Walford, but Dr. Longo says this still may have other health implications, because even though these patients had less cancer and less cardiovascular disease, could that induce the emergence or contribute to the emergence of other diseases like ALS? I don't think we know that, but he thought there has to be a better way. So he started working with yeast first, yeast cells, and he found that when he would switch them over to a medium that gave them no nutrition, the yeast would live longer if he did that intermittently. Then he switched to mice, and he's also working with humans. But there was a mouse experiment, and granted, the caveat is not everything that works in mice works in humans, but it's a good start. And there was an experiment. So they took mice with cancer. These mice had cancer, and they had a control group and an experimental group. And they took the experimental group, and they switched them to a water-only diet 2 to 3 days prior to high-dose chemotherapy. The control group, they kept eating a regular diet up to and through their chemotherapy. And what they noticed that post-chemotherapy, there were alterations in behavior. So the non-fasting mice eating the regular diet were sluggish, tired, just as you'd expect. The mice that were switched to a water-only diet seemed still pretty active. Then they waited several weeks, and 65% of mice in the control group who were eating the normal diet had died. Nearly all of the fasted mice were still alive. So the conclusion that was drawn was that fasting seemed to confer some protection of normal cells against chemotherapy, but it did not seem to compromise anti-tumor activity, which is always, of course, very important. Next slide, please. Okay, And so there was a small trial several years ago looking at, oh, yeah, we go, looking at patients receiving platinum-based chemotherapy. Platinum, I think it was cisplatin, which is a very harsh chemotherapy, very nauseating. And less than 20 patients were placed on a water-only fast for 24 or 48 or 72 hours prior to chemotherapy. And what they noted was that 72-hour fasting was more effective than 24-hour fasting for side effect prevention. Certain things were similar between the two groups. Neuropathy and hair loss were similar between the two groups. They maybe should have used cold caps and cold packs on their hands and feet. But for many of the other side effects, like nausea and fatigue, the side effects were less. However, water-only fasting is so difficult. It took nearly 5 years just to get 18 patients through it. So questionable if it's really feasible to do that. And again, I start getting nervous when patients are going 48 hours or longer on water only. Next slide, please. Okay, now, so I'm a bit of a proponent. I'm a proponent of this, or at least having a patient, offering the patient the option, having them think about this. It's, again, probably even more difficult than trying to do cold caps. Remember to ice your hands and feet. It requires a big commitment. And we're not 100% sure that it works. There are ongoing trials. Dr. Longo, there is a company that manufactures kits for the 5 days of the fasting mimicking diet, where it's plant-based and vegan. And the key is that it's low in protein and low in carbohydrate to induce a ketogenic state. And the last I heard, they were trying to develop one for cancer patients. Well, the challenges that you have with cancer patients is taste buds are changing. They might be nauseated. And so they might like your soup one day, but 2 days later, they can't even look at it. They can't smell it. So that has been a consistent challenge. We're not entirely sure that it works. There was a recent publication of a trial called the DIRECT trial that looked at fasting mimicking diet in women with stage 3 HER2 negative breast cancers. And these women were undergoing preoperative chemotherapy. There was 131 women randomized, and the experimental arm was, they got a fasting mimicking diet starting 3 days prior to chemotherapy. Now, here's the interesting thing. In the group that was doing the diet, they omitted the steroids. For you women that have had chemotherapy, steroids are such an important component of the treatment to ameliorate the toxicity. And that's an area of real struggle between us and researchers like Dr. Longo, who would like us to get rid of the steroids, but I also don't want to have a patient that's really sick. So in this group, the steroids were able to be omitted. Now, here's the thing. There was no difference in toxicity between the two groups. So that was somewhat surprising. And there was no difference in what's called the PCR, the pathologic complete response rate. So that is the brass ring, the holy grail when you're taking chemotherapy pre-surgery, is when you take all that chemotherapy, you slog through all that, you get your surgery. If that tissue shows no live tumor cells, wow, that is a fantastic result. Unfortunately, that only happens in 40 to 45% of the time, depending on what type of breast cancer that you have. And so they didn't see a difference in these patients. They did see a couple of things. Number one, when they looked at I think that's really elegant. They looked at this. They looked at these patients' T lymphocytes. Lymphocytes are a type of white blood cell that are part of your immune system. There was less DNA damage in those T lymphocytes. And as you know, lymphocytes can be important as far as our own immune responses to cancer in our body. So that's intriguing. Now, do we know if that impacts survival down the line? We don't. Also, there was poor patient adherence to the dietary modifications. And I think I previously mentioned what challenges we face with taste change and nausea. So that was disappointing, but still, even though it wasn't as successful as I would have hoped, I do think there were some intriguing findings. The other thing that intrigues me is they were able to, even though there was no difference in toxicity, they were able to omit the steroids from the experimental group. And that's huge because we're all so shy about doing that if that can be done, there may be some benefits to that as well as risk. Next slide, please. So challenges in doing this, for instance, which patient would I tell not to do this? Very interesting. I was talking to someone yesterday, and she said, oh, I read this book, The Longevity Diet and Fasting Mimicking, and should I do that? And she was severely underweight. And I said, absolutely not. So if you already are having a lot of weight loss, this is not something that I would recommend for you. If you have an advanced age, you're already non-functional, I'm going to, restrict calories. I'm going to make that worse. It can be challenging if you have comorbid disease like diabetes, because I don't want to make someone hypoglycemic if they're on insulin. So we have to be very careful. And also, again, as aforementioned, taste change during chemotherapy, other symptoms make the diet intolerable. If you're trying to do this on your own, it is challenging. You would have to really plan it out. I think that's all of my slides. Oh, good, I've got a summary. Okay, so some toxic side effects can be ameliorated by direct intervention, cold caps for hair loss, frozen gloves and socks, and dietary modification. Obviously, results vary. They're directly correlated to adherence. That's especially challenging. You're already not feeling so great from chemotherapy. It's a very difficult time. So it takes a very motivated patient to do one or more of these interventions. And with that, I'm happy to take questions. I know I didn't get to fertility, but I'm happy to answer any questions if you have questions about that.
Thank you so much, Dr. Cline, for sharing those choices patients have in their treatment. And we have received a couple of questions, but we still encourage people to ask those questions now in the Q&A section. We'll start with the first one, and it says, Amy Price, will fasting possibly lessen the efficacy of chemotherapy?
So thus far, we don't see that it does. That's because it's questionable that the tumor can utilize ketone bodies like your normal tissues can. Also, as I said before, a fasting state or a fasting mimicking state or a ketogenic state, your own tissues kind of are less active. But again, for tumor cells, they can't be less active. They're turned on. So they should get the full effect of chemotherapy.
Thank you for answering that question. And from your experience, what have been the most popular questions in regards to this subject?
What are the most popular? Gosh, I would say people are pretty interested when we talk about dietary modification to try to prevent toxicity. I would say that and neuropathy, just because, it's such a bugaboo. You're still struggling with that. Eventually, you're going to feel better when you stopped chemotherapy and get back to normal, but you may always have neuropathy. So I think people are very interested in that.
That's right. Thank you so much for sharing all the information and for being with us today. Any last comments to our attendees?
No, if there's any more questions, I'm happy to answer. I'm happy to try to answer them. I think I saw something pop up from one of the attendees asking that you still struggle with neuropathy. Is there anything that can be done? So there are some medications that can help with the sensation. Gabapentin is one. Gabapentin was first approved as a seizure medication. Nobody uses it for seizures anymore. It's generally used for neuropathic type pain syndromes. And so medications like that, or pregabalin, also known as Lyrica, patients can get a lot of relief, but you have to keep taking the medication. One aside, I should say, there was a recent study looking at a dietary supplement to try to prevent neuropathy. I believe the dietary supplement was L-carnitine. Patients in the L-carnitine group actually did worse. So I don't recommend supplements. I know there are some naturopaths looking at injecting alpha lipoic acid at the site. I don't know if that's successful. I haven't seen studies yet. I've just had patient anecdotal reports suggesting that it might be.
Perfect, thank you. We also have one more question from Amy Price. It says, what specific dietary advice might you have for recovery from treatment beyond a normal, healthy, balanced diet?
Yeah, that's a great question. So when you're trying to recover from treatment, I think you can do the fasting mimicking while you're getting chemotherapy, maybe 2 or 3 days before, the day of, and the day after. You might do that for several cycles. But when you're in recovery phase, you've got to then make it to when you get to surgery. That's when I think protein's important. and make sure you're eating a varied diet, that you're getting all of your vitamins and minerals. I think that's important to try to be in the rebuilding phase, let's say. And interestingly, when outside of cancer, when we talk about doing a fasting mimicking diet or a fasting state, there is talk about, okay, how do you rebuild? And it is, okay, now you need to get enough carbohydrates and enough protein to really rejuvenate stem cells in different areas and that sort of thing. So I think protein's important when you're trying to rebuild.
Thank you, Dr. Cline. Also, talking about diet, we have a question. It says, what are your thoughts on breast cancer patients eating meat and dairy?
Eating meat and dairy. So, I think that this is, it's still evolving. I would say that with meat, especially red meat, yes, there are definitely studies showing higher risk of certain cancers with red meat eating. More on the GI side. Dairy, I don't think we know. I don't know, but I understand the concern because yes, you're drinking a substance from a pregnant or lactating cow that's full of hormones. But I also know we're concerned about getting enough calcium and vitamin D. So I don't tell people to restrict dairy unless they have specific problems with dairy. For meat, I don't tell people that they should never eat red meat, but they should limit it in their diet. Also, if they can afford it, consider grass-fed red meat, which seems to have a much better profile as far as inducing alterations in lipids than grain-fed meat. So.
Sounds great. Well, thank you so much, everyone, for participating. Thank you, Dr. Cline, for sharing your time and expertise with us today. We also want to thank Texas Oncology and Telemundo Austin for their support. In addition, we appreciate all of you who joined us today. Komen will follow up with you with links to the resources mentioned during the presentation and common resources to support you. We hope to see you in future events. Have a great day, everyone. Happy Wednesday. Be well.
Thank you so much.